We envision a movement.
We envision a movement.
We envision a movement of God's people.
A movement of God's people.
God's people who choose daily.
Who choose daily to promote healing
in marginalized communities in the name of Jesus.
In the name of Jesus.
In the name of Jesus.
Well, Lance Loberg, I'm really honored that you're here, and I appreciate you making time to do this. This is our first time really to spend any real time together, and it's just an honor to meet you. Thanks.
Sure. You're welcome. I'm honored to be invited to give a little of my story and how it relates to CCHF.
So, if you take a look at the paperwork on CCHF, for years, we have talked about John Perkins as being sort of the father of CCHF, but John Perkins' name's not on any of the paperwork. It's yours and H Spees, when we look it up. And you guys had a relationship with John, and so then I think that was all back in 1978. That's when the corporate papers of CCHF started. You were a pretty young guy back in 1978.
That was my third year of medical school, and I became a Christian shortly before going to college. And then during college, it's early 70s, civil rights movement was going on, Vietnam War, and trying to figure out what does that mean as far as Christian faith. And so, I struggled with that. And so reading publications, one of the ones that's now Sojourners, John Perkins was one of the columnists for that. So that's when I was first introduced to John Perkins. I liked his style of writing. It was this is what the gospel says, this is what you should be doing. Then when I went on to medical school, sophomore year at the University of Washington, that would have been December, I guess. With Christmas break, I went to Urbana, and John was one of the speakers. And that's when I first heard John and kind of met him briefly. Introduced to his books, read his books on Quiet Revolution, and learning about his approach to community development, which interested me from a Christian perspective. Like, well, what does it mean for us in the U.S.? How should we be living as Christians? Many of I was part of Christian Medical and did all this association society back then. And it was great folks, but mostly talking about overseas missions. And there was not much about what does it mean for what we do here and what we choose to do. So partly to answer some of those questions and to explore more from my own faith, I ended up sitting a public health elective through the public health department at the University of Washington at the medical school so I could get credit and still be a full-time student. So I went out for residency interviews. I arranged for a month to go to Voice of Calvary. I had a contact with
because you wanted to do residency in New Hebron, Mississippi.
Well, actually, I had not. I had not. Retrospectively, I wish I had actually set up a interview at the University of Mississippi. Those were set up months before, so I didn't have that. So, but I finished my interviews, then went to Jackson, stayed with a friend of one of my roommates was working at Voice of Calvary in their housing ministry, and so that's one of the contacts I had there. And I started working with H Spees, and that was when I first met H.
Yeah.
And H was involved in working on developing a health center in New Hebron.
And so Voice of Calvary was an organization that was started by John Perkins, right?
Yeah.
And originally, was it in Mendenhall or?
Mendenhall was, where he grew up.
Yeah, Mendenhall, Mississippi. New Hebron's not far from Mendenhall.
Correct.
Yeah. And then, but there was no health center there.
No, there was a health center in Mendenhall. And I'm not sure how much that was affiliated with Voice of Calvary. When I was there, we stopped at the health center, but they were really looking at more of a health center's outreach in New Hebron because some of John's history. I think his brother was killed there.
Yeah, right.
And so my month there, I spent time with H, went to the Rural Health Conference, explored kind of what it's going to mean to start up the Rural Health Center there. But what we found was, of course, Calvary from John speaking had a lot of contact with medical students, dental people that were interested in that and possibly at some point working in a place like the Voice of Calvary or one of the ministries. So it seemed like, and as I saw it in my own life, is there's culturalization that occurs as we're in training, as we go through medical school and residency, and a lot of the original sort of values we had for going into it, with Christian faith to serve in an area that underserved, we tended to lose. And so part of our discussion, H and I at the time, was how do we network these folks? How do we keep that vision alive of as part of our faith, we live out the gospel, serving the poor, underserved, marginalized. So that was part of our discussion at the time with, what do we do about that? How do we recruit folks for this new health center that's going to be started?
One of the early publications of CCHF was Upholding the Vision. Is that where it got its name? Is that what you guys had in mind?
Yeah, that was one of the early books that was written, and it was written, I think, partly with stories that had come from the original newsletter called Health and Development.
Right.
So after my month there, I went back to finish medical school. I got my third year, so I had another year to go. And I had to, for my public health elective, I had to write a paper. So I wrote a paper on healthcare and community development, modeled mostly after John's writings and other research on rural healthcare and needs. And continue to dialogue with Age. At that time, of course, there was no internet, there was no emails. There was all either calling or snail mail mostly. And so in my fourth year, when I was finishing up, I had some time available. I originally was going to go out of the country to do a mission position. I decided not to do that and decided to go back to Mississippi. And part of that was I actually ended up rewriting my paper, making it put a little more beat to it, and turned it as an honors thesis on healthcare and community development. So it was part of the sort of underpinnings of how do we form an organization to help recruit people, help network people. So I went back down to Mississippi in May of 1979, and H and I sat down and said, well, what are we going to call this thing? And they said, well, we're Christian. We're about the community, about the Christian community, the church's community, and we're about health more broadly in all the aspects, not just doctors, dentists, but all the people who would be in a clinic, all of the broader implications of that. And that was before we talked about social determinants of health.
Right.
And then it was a fellowship. It wasn't meant to be a society where you're in, the other person isn't, but we're a fellowship. We're all part of it. So that was kind of the initial vision in the name. Then we thought, well, what is our motto? And it was really about living out the gospel through healthcare with the poor. So that we came up with the motto, came up with the letterhead with the CCHF and the small letters. Printed up some letters to send out, and started writing the first page of the first health and development was a mock interview between H and I, asking questions of things we've been dialoguing on. So we wrote those into some articles, and then published that and sent it out to the mailing list, mostly Voice of Calvary, and that was kind of the start.
That's neat. We've got a copy of that very first HD. It's like a newspaper.
Yeah,
yeah. And I think we may have like a PDF of pictures of that, that you can actually go back and read on our website somewhere back in the archives. But that's really neat. So in a way, CCHF kind of almost started as a research project when you were a medical student.
Yeah.
Wow.
Yeah.
That that's exciting to me. We've got medical students that are presenting posters at our CCHF conference, and that are, trying to figure out how to make their research work in this kind of world. And that's exciting. How do you feel that was 1978?
Yeah.
So however many years ago that was a long time, 46 years ago. Is that right? Am I getting that right?
98 and 45. Yeah.
45, 45 or 46 years ago. I mean, how do you feel? Apparently your research project did good.
Well, they accepted it. I got a whatever T beside my name on the graduation that I did an honors thesis. But For me, it was more just exploring what is really trying to kind of flesh out what does it mean to live out the gospel and what are options for us. And compared to some of the posters up there, it certainly wasn't as scientific as that. It was really much more about what is health, what is community development, how do we do those things for and what is our calling as Christians, and in a public writing it for a public medical school. But I am sort of a lot of the sort of bylaws and things we had to do after that, and a lot of those sort of things were kind of fleshed out, particularly with H and using Voice of Calvary's motto. And I think we used probably initially, I don't know when we got a 401c3, or whether I think we initially used Voice of Calvary's as we were coming out of there. And then it was putting together a board, kind of getting the 2 years, 82, I guess, the first conference.
So you stayed involved through all of
Yeah.
that. And
So I was actually in residency then, but then as we were putting together the board and having meetings, we would have like a board meeting with some of the early pioneers, Ray Downing and Tennessee, outside of Knoxville, and J.D. Miller in Kentucky, and were some of the folks around the early board and involved. It seemed initially was more as many rural as urban folks, but then also got involved with the urban folks, Janelle and Getchus in Washington, D.C., and Carolyn Klaus in Philadelphia. And
a lot of those people are still involved. Ray Downing eventually moved to Kenya, and he did a lot of writing. He's written several really good books, and and he lived in Kenya a long time. He died a few years ago and gave instructions to be buried in Kenya he just loved that country, and he loved the work that he was doing. He stayed real involved with CCHF through writing when we had H&D.
Right.
And there's a lot of really excellent articles that he wrote that are still available online through our website, from that. And J.D. Miller passed away last summer, and but J.D. stayed very active. He was on the board. He helped start a couple of different clinics in rural Appalachia and eastern Kentucky, and was on faculty at the University of Kentucky Medical School for a long time. And he was at this conference last year.
Yeah.
And we're in Cincinnati right now, taping this. But so I'm sad to have missed an opportunity to get JD's story. But I think he was maybe at one of the rural conferences that you guys went to. I think that was what he told me, how he connected with you guys, that y'all were at some conference on rural medicine together or something, or rural healthcare in Atlanta or outside of Atlanta or something. So what are you doing now? You're in Salem, Oregon.
Right. So I'm a family physician, and so I spent most all of my career in either community or clinics, or so currently I'm working at for the last 10 years I've been at a tribal clinic called Grand Ronde Health and Wellness. This serves Native Americans. I also have a side job doing serving medical care for 2 county jails as well on my day off. So.
Yeah.
But and prior to that, I was 17 years at a community health center, and also 4 years at a migrant health center in the Salem area.
Yeah. But you're not from Oregon originally.
So I originally grew up in a small town in kind of a center of Montana, a town called Stanford. So my first degree was from Stanford, and a small town of about 500.
Yeah.
So, but I went to undergraduate at Montana State University, and that's where I started reading more of the Christian periodicals that kind of pushed my faith in those sort of questions.
People, Jim Wallace and John Wallace, or some others like that. So, when did you decide you wanted to be a doctor?
I started in college actually with the engineering degree, but it was like the summer before I went to college that I made a faith commitment. Then I thought, do I really want to be an engineer? And I had questions about it, so I still did that first couple of years of all the engineering physics and math, and I want to do something more that combines science, but is more directly involved with people. And so that's why I decided to look at as medicine instead of that. Because I think engineering probably retrospectively would have been fine. I like doing projects and designing stuff, but so that's what I decided that maybe medicine would be better. And so for me, that meant actually doing the 5-year program at undergraduate, because I had to catch up some of the coursework, and I didn't. Part of my questioning, should I do medicine or not? I actually got a job in the summers and on breaks, like Christmas break, spring break, working in a rural hospital in Havre, Montana, right by the Canadian border. So I could get some. Back then, there wasn't the whole thing of doing that to get into medical school. As part of that, I was answering my own question. Well, what does medicine mean? What's going to look like? So for me, that was getting some experience to see, is this something I want to do?
And it stuck.
It's stuck. Yeah.
Yeah.
So,
you wouldn't have had your public health elective if you'd have gone into engineering. Yeah, no, yeah, for sure. There would be no CCHF probably. You know, so I'm grateful that for lots of reasons that you chose to go into medicine, and then you did residency. Maybe was that in?
My residency was in Colorado.
In Colorado.
Yeah. And so that was just when I went to Mississippi the first time I had been on a residency trip, interviewing. So I had a list of residencies they thought were good residencies from our, family medicine department. And so it was one of the ones I interviewed in that I matched. And so retrospectively, if I had known more about Mississippi and the possibility of being there, I may have looked at that. I mean, at that time, there were really no Christian health centers or residents associated with them like there is now. And so there was really, of course, again, no internet or emails or things where you can connect with folks. It was much more trying to figure out what was available. And
yeah. And so residency in Colorado, you had this connection in Mississippi. How'd you get to Oregon?
So to pay for medical school, I took a National Health Service Corps scholarship.
Okay.
And so and I looked at the option of whether I could do that in Mississippi, but New Hebron, which is started, but then didn't need any physicians. And the other clinic, they were just getting started in Jackson, didn't have because maybe Jackson didn't qualify as a health manpower shortage area, didn't have funding for the National Health Service Corps scholar. And so I ended up going back to the Northwest and ended up serving in a migrant clinic there. So I did that for 2 years initially, and then decided I needed to learn Spanish. So I went to Mexico and learned Spanish.
No need.
And then I actually spent a year working with Salvadoran refugees with Church of the Savior of Washington, D.C. with
Dr. Getchus.
Yeah, and then went back to the migrant clinic I was at.
Yeah.
And then ended up leaving there and going to Cambodia for a year with the NI Central Committee.
Oh, okay.
So I always had the desire to do something overseas, and it came up, and I thought I would go do that. So
yeah. Well, you're settled in and working with the travel clinic now, and I want to come back to that in a minute. But let's talk a little bit about like early days in CCHF. So you started CCHF. It was it sounds to me like, see if I'm getting this right, but it was at the time it was probably mostly about a newsletter that was or a journal or something that was going to go out, and you started with the Voice of Calvary mailing list, which basically was the John Perkins fan club. Sort of.
Well, particularly the people who had written into them or were interested in what they were doing in healthcare. So particularly targeting those folks.
Yeah.
And I'm sure H had, connections with folks also that he used. And I can remember back exactly how the connection came up with, for instance, Janelle in DC.
Yeah. So how did things develop into sort of this sort of network of clinics? And I mean, the fact that you guys called it Christian Community Health Fellowship, you had something in mind. You kind of envisioned a community. I would sometimes.
Yeah, I think envisioning that community was both a community that would support one another as far as with folks involved in healthcare as a ministry, but also that sense of the church's community that, that could be part of what the church is doing as part of development as well.
Yeah.
Particularly, I think, as far as the model of the Voice of Calvary was trying to do in their both having health center in Jackson and one in New Hebron. And there are other health centers that have kind of followed that model, like Lawndale and Chicago.
And somewhere in all that early days, you and H visited the clinic that was up in the Mississippi Delta. That was a Christian clinic.
Right, and that was actually when I first went to Mississippi for that month. And we went and visited Peter Boland's at Cary Christian Clinic in the Delta, and talked with him about his experience. And
he had written a little book. Did you read that book, A Delta Doctor or something like that? It was published through the Luke Society.
Yeah.
I've met a lot of people who were inspired by that book, many, many years ago that decided, hey, this is kind of the kind of medicine I want to do and that kind of thing. So what was it? What'd you learn at Cary? What'd you see? What'd you learn? What was that like?
Well, certainly, that's the first time I've been in the Deep South. So, seeing both the, poverty there, but then also people doing a ministry there that was needed. So I was inspired by that. I think more specifics than that, so a long time ago. So I just remember having been there and being part of that kind of inspiration for here's somebody who's doing something that, and my memory is that Peter had been in Korea, I believe,
right
prior to that, and so the whole I thought there was could be a lot of intersection of people who wanted to do overseas ministry, but also in the States do ministry, and that there was a connection with that, and a place both could be a launching pad for people to work overseas, but also when they come back and have a place for ministry.
Yeah. And then you served on the board of CCHF several times over the years. And I don't know, just talk for a minute about how, like, what when you started the newsletter, which was called Health and Development.
Right.
I mean, how did that morph from that into a conference? And did you guys have sort of a vision for how it was all going to unfold, or was it following as it wound?
I don't think we had a 5-year plan per se. It's more as we met as a board and talked about what do we want to do next, how do we grow this, and encourage people. And so I think conference kind of grew out of that desire for people to come together, a part of part of the upholding the vision saying. Yeah, and also see in some of the early conferences, like the first one was in D.C., so you could look what was going on as far as the Clinton Road Health Services, and I believe that was before Christ Houses started, but at least hearing about the need of the homeless in D.C. And another one, I think the year after that was in Esperance in Philadelphia. So some of the earlier ones in inner cities, they were not big gathering. One in D.C. was Luther Memorial Church. It was not a big place, so I'm not sure how many. Maybe 100 folks. And a lot of us stayed with families that the Church of Savior knew in the D.C. area, where we could have the experience of living in the city as part of that, similar to the Esperanza one. So there were, and not very fancy meals in the church basements. And so they were pretty low budget conferences, but it was a way of starting a network and also see what was, get a real sense of what would it be like to live in this inner city Philadelphia or in D.C. and be part of this. So it was an experiential conference as well, partly with visiting the health centers or just being there.
So 82 was the first conference, I think, and it was in D.C. My understanding was that John Perkins and Janelle Gatchis were
the keynote.
Were the kind of keynote speakers, and was Columbia Road Health Services, was it up and going at that time? So there was a clinic there.
Right, there was a clinic there.
And that you guys probably visited. Yeah. And Church of the Savior was a very important influence in all of that. And when you guys moved to Philadelphia the following year, had Esperanza started at that point? Because I think Carolyn told me that she'd been thinking about doing something, but pulled the trigger really after she went to that first conference.
Right. I think
And heard Janelle Getch's sharing in 1982. And then went back and she and Ron started
that.
Esperanza. Yeah. Long time ago, huh?
Yeah, well, I'm trying to remember exactly. Was it the next year they had the conference, or did they go 2 years? I can't.
Yeah.
You have to try and pull out old documents and see if there's.
That's all right.
But
That's all right. When did, so we started in Mississippi, and I think it moved to Pennsylvania maybe next. Was that because she hired an executive director? Or?
Yeah, so initially, executive director who was actually lived in New Hebron, because I actually had the H moved to New Hebron, and since he was the main person in Mississippi being involved with the organization, hired executive director who lived in New Hebron. But when Jerry Cochran is her name, had done her 2 or 3 years, however long that was, and needed to move back to California where she was from. Me and one other executive director after that, I think Steve Crane was the director, but then when they were recruiting for executive director, David Kays was interested in, and he lived in Philadelphia. So then so that's when the office moved to Philadelphia.
Yeah. Well, great. So it's been a long time since you've been to a CCHF conference.
Yeah.
You've been here in Cincinnati with us at the 2024 conference for the last couple of days. Looking around, do you recognize anything? Are we upholding the vision? Are we being faithful to, what you and the founders had hoped it might do?
Yeah.
Be honest.
Yeah. No, I mean, when we threw it out saying there's a need for this, because there are obviously people writing a voice of Calvary, and there's a sense that of the culturalization happens through school where we lose our vision. How can we help us hold on to that vision? And so I think very much so has helped in maintaining that. And I think the conference is the same as in the years past, but very similar. We have great plenary speakers who encourage us. A lot of timely workshops in different areas, both for running health centers and dealing with issues in health centers, as well as just how to do ministry, how to minister. So I think very much is upholding that vision.
Well, good.
Yeah.
I hope so. We tried to be faithful to the foundations in the years that I've been leading CCHF, and stayed close to John as much as we can. John's very old now and is not able to be around as much, but H was here last year, and he went to be with the Lord this year, and shortly after the conference, unfortunately. And so,
yeah, it was one of the things that motivated me to come this year. I said, I attended virtually last year, but was disappointed that I hadn't come in person and ended up with H. So,
yeah, there's a verse. Some people probably. I wouldn't necessarily encourage somebody to build an entire theology on this, but, where Paul writes and he says, the church is built on the foundation of the apostles and prophets, Jesus Christ himself being the chief cornerstone. And, when I read that, I think, well, it doesn't say the ministry of the apostles and the ministry of the prophets, or the teachings of the apostles and the teachings of the prophets. It was built on the people themselves. It was, it's a building of living stones, and I just appreciate the fact that there were real people who didn't just have an idea, but who fleshed it out, and and were, if you will, they were a witness to what they thought it was supposed to be, what this was all supposed to be. And I appreciate you guys being committed to living out the gospel. Talk to me just for a minute or two about we've had a lot of people who've been interested in over the years. A lot of folks will call and say, "Hey, is there a Christian clinic that's serving First Nations people. And of course, there's the Indian Health Service, and a lot of Christians have gone to work through the Indian Health Service to try to serve that population. In terms of disparities, there is not another population that has worse health outcomes in terms of disparities than First Nations folks. And I don't know, talk about that a little bit, because that seems to be a passion of yours and something you're...
Yeah. So one of the things I learned from actually when the HR person talked to me when I first went to work for the Grand Ron Health and Wellness for the Confederated Tribes of Grand Ron, said, you're being invited in by this nation. And like if I were working overseas, I'm being given a permission to work there. So they're inviting you to come and be here and serve them and work with them. And so it's been a perspective I've had to think that I'm not coming here to say, I'm going to do all these things. I'm coming here to serve and to find my place within that. And I think, and I've learned, had to say, well, what does that mean as far as being white? Well, the history of colonization has happened with natives. These are the tribe that in the 1800s were marched from southern Oregon by the coastal range into a reservation, kind of their own Trail of Tears. And so they have then lost their native status, their tribal status when in the 30s when that was coming down, and then finally regained tribal status in 1986. And then started rebuilding from there to kind of take care of their people. And so knowing that sort of history and the history of trauma, I'd say, well, how do I fit? I'm not coming in there as a person that have all the answers, but to both hear their story and their trauma and see what I can be as part of a healing presence within that. And I've learned a lot from their own native spirituality, and like every meeting we have is usually opened with a prayer, and it's to the Great Spirit, or sometimes it's the Lord's Prayer, and so there's a lot of intersection with faith with that, but a real sense of spirituality there. And so I don't go through with a sense of I'm going to make them all Christian, but the sense to serve and hopefully I can be a Christian who's serving in that place and try and find my place within that. And we have a history of the church and colonization kind of marching hand in hand over the old manifest destiny and theology, and a lot of that tied together. And so trying to avoid that as what I'm part of, and just being there to kind of be a servant.
Yeah.
And I take one of my patients as a pastor of a local church who's native from that tribe. And so there are folks within that are more professed Christians than others. But
just in terms of just health and just medically, what's the difference for you? Like, what are you seeing serving that population as opposed to other populations that you've served?
Well, for sure we have a lot more diabetes. I think that's fairly well known. And then the native population has a higher incidence of diabetes. In general, tends to be more maternal mortality, although we don't have a huge OB population, so I haven't seen that so much. Certainly a lot of stress, mental health related, trauma-related illnesses. So they try to take care of their own. See if there's trauma within a family and somebody needs to be put into foster care, they try and do it within a native family. So we do see that. So there's certainly trauma and intergenerational trauma that gets expressed, and trying to understand that, and as far as realizing that there's that trauma history behind a lot of the things that people are coming in with, PTSD or other trauma-related symptoms.
Yeah. And, I think a lot of us don't really understand kind of what the healthcare structures are for
Right.
for Native Americans, First Nations people. There's tribal clinics, and then there's the Indian Health Service or IHS clinics, right? And so IHS is runs kind of like the VA, sort of. It's a federal government program that is.
So IHS is the federal funding for for natives. And I think maybe because of the distrust of IHS and them running clinics, there was a law passed by Congress, I don't know the exact year, that allowed tribes to take the funding that would have come to for IHS to run a clinic and then for them to run their own clinic. So they get actual tribal funding, and then they could set up. So I'm hired by the tribe. I'm not part of the Indian Health Service or Public Health Service. And I would say there's probably more tribes doing that than there are Indian Health Service clinics.
So is there, I mean, there's a huge health disparity. I mean, when we just take a look at the data, is there a shortage of primary care for First Nations people, or is there a cultural barrier for them to receive primary care? Like, should we be recruiting CCHF kind of motivated, Christian community health motivated people to focusing more on that in that area, or is it sort of a, like you said, you have to be invited in, you have to be?
Yeah, well, there's a need as far as recruiting folks. I think many even private practice clinics have a hard time recruiting primary care right now, so it even gets harder than I think in places that are more rural and underserved have a harder time. So I think definitely there's a need, and for people who'd want to serve in those sort of clinics would be very helpful for CCHF to be involved. I know last year I listened to one of the workshops that a couple did that were working in South Dakota with a Native population, and I was encouraged that we had that as a workshop, and so
Yeah, in Cali Lukey.
Yeah,
Or up in Turtle Mountain.
Yeah,
in South Dakota. Yeah, northern South Dakota, or northern North Dakota. Actually, they're right on the Canadian border. So
I'm still. I mean, I've been there 10 years, and I'm still learning.
Yeah,
a lot and this. I've always heard, well, it takes a year being somewhere to get a sense of what it is. I think probably a lot longer than that.
Yeah, right. Well, I'd love to have you come back sometime, and maybe next year you could come and do a workshop on, on what does cultural competency look like, interfacing with First Nations people. I think something like that would be really helpful to us. But and then another area of interest that seems to be growing in CCHF. I've had a number of individuals that have contacted me, and a few of them with organizations that have said, listen, we're pretty good with the foreigner. We're pretty good with widows. We're pretty good with orphans. The one that's left that we're not doing much with is prisoners, and how do we, I know that there's a group in Alabama that reached out to me recently and wanted to know, how can we do a better job with healthcare in prisons, and he had a plenary speaker this morning at the conference, Dr. Ezike, who spent years working in the juvenile detention centers, the largest juvenile detention center in the country in the Chicago area, and then she made the comment, stewarding her role as the state director of public health for Illinois during COVID, how that God had set her up to kind of be uniquely equipped to address COVID in the prisons because of her time working in the detention centers before. And the comment that I think stung all of us is she said, there were people in prison that maybe they committed a crime and maybe they didn't, but they didn't sign up for a death sentence. And she was just talking about how the healthcare in the prisons, especially in, when you've got infectious disease and things like that running, just the issue there. But what's a way in for that?
So there's definitely a need. And jails and prisons are different. The prisons are always more going to be a state job generally. Jails are usually county run. And sometimes it can be contracted with an outside agency that provides care for them. But a lot of times, like the jails I help cover, it's just a self-employment contract with helping cover the jail. And wasn't something I went looking for. The first I was working with at the tribal clinic was covering one of the jails, and then one of the other jails lost their provider, and they asked him if he would cover it. And it's a 500 inmate jail. It breaks 2 clinics a week. He said, I can't cover it myself. So he asked me if I would join him, and that's how I got involved with that. Then about a year after we were into that, he died of a heart attack. And so here I was picking up all of that jail, plus the jail he was doing, and I was also seeing a smaller jail. And I recruited a nurse practitioner to help me. I couldn't carry all that and work full-time at my other job. But the incredible health disparities there, lots of mental illness, a lot of drug use. Now we have a MAT program, Suboxone in the jail. But it's part of the problem with dealing with health disparities. I'm not sure if that's nationwide, but at least in Oregon, people coming to Oregon has early on adapted a type of Medicaid waiver where they have not just women and children can get Medicaid, but it was extended before Obamacare to other folks. And so, but one of the problems with that, when people go to the jail, they lose that coverage. So it's all on the county. So part of my job is saying, well, what do we need to cover? Are we going to pay for this guy that needs a knee replacement, he's needed for 10 years, and now he's kind of free of being on methamphetamines and he has a place to stay? We have done a few of those. One that was there the day after his surgery was released. How's that for recovery for his knee replacement? As you have to be real careful deciding, are we going to pay for these or not? We do pay for people who have big hernias that are causing real problems, but not every small hernia. But part of it's that how do we justify paying for this with the county funds so being able to actually have Medicaid where you're still in jail would be a great step forward as far as for that disparity. Having a better, at one time the sheriff came to me and said, well, why do we have nurses that go out and see the community after they're released? I said, well, may or may not be the safest thing to do, but if you just had a health coordinator, so you make sure Oregon Health Plan gets back on, you find out which plan they're on, hook up with a primary care provider so they have an appointment when they leave. So that would be a better step, because then at least to me that overcome those barriers. There's a lot of those barriers in the jail that, and it's a tough place to work. I've become, I wouldn't say hardened, but I've learned how to say no more.
Yeah.
Because a lot of folks have they're dealing with people they're trying to get what they can. We're in the jails. You have to kind of decide what's really necessary and what isn't.
Right.
But it's there is an area with huge needs, and it would require a lot of more funding, at least in Oregon, from our county to really have a program that would meet all those needs and catch up on the things that haven't been caught up on. We do things like treat their diabetes, hypertension, the usual medical things, but we can't get them all joint replacements or even treating hepatitis C, which I think would be a good place to do it in the jail. But the cost of that, plus are they going to be there long enough to complete the course? And so generally we don't even test for that, at least in our jail, but it would be something you could add on. We are doing some, Suboxone treatment at least now. But mental health is the other big area. And we had a lot of people who were mental health issues in the community. They get put in jail, and it may be a couple of months before they can go to the state hospital when they're really severely mental ill. And the psych nurse practitioner works with them, but sometimes they refuse meds, or they're just in a cell trying to do the best they can taking care of them until they get to the state hospitals. That's where society puts the people who have drug using and mental illness, and that's where you see them, as in the jail.
This is an area where we're seeing a lot more interest, and I think that God cares about that, and that's part of the gospel call that we've been given, is to take good news to those who are poor, to the widow, the orphan, to those who are sick, and also to the prisoner. So, is there anything else you want to? I don't know. It's your opportunity to kind of have an open mic.
Yeah,
to see the world for a minute.
Yeah, I'm very honored, and CCHF has continued to go on, and people like Steve has been here to help with the vision and network with the folks and carry it forward. So I'm honored to be here and join back in the conference and see the progress that's gone on from the years ago.
blesses me that you feel that we have been somewhat true to maybe developed it, but that we're of the same ilk then that things started. I'm grateful for you and just how God sort of turned things around so that this could happen. So thanks so much for giving us some time.
Thank you.
And I hope we can kind of keep working together
Yes,
over the next few years. So
that would be great.